Welcome back to the Lift Free and Diet Hard podcast. I'm your host, Andrew Coates. Join me along with industry leaders and friends on a quest to get more people through the gym door and eating and living healthier. Join me where evidence meets empathy while rejecting fitness industry fads and extremism. Let's begin. Dr. Gary McGowan. This one's a treat because I've been trying to get someone to come on for a little while, credible, to talk about a lot of cardiovascular disease, health-related issues. And you have a unique resume. I mean, in addition to being a medical doctor and having your master's in preventative cardiology, your background's also as a physical therapist and then personal trainer before that. So all these aligned things that work out really well. Not to mention you're also a purple belt in Brazilian Jiu-Jitsu. So that's pretty badass.
Thank you. Yeah, no, this is the perfect crossover of interest for me, really. I kind of got interested in cardiology because it happens to sit at a very nice crossover between my interests like exercise physiology, nutrition, and then medicine. So yeah, cardiology is an interesting crossover of all of those things. So you get your little bit of exercise physiology in there. Exercise and nutrition are obviously super relevant for the prevention of cardiovascular disease, as we'll talk about today. So yeah, delighted to be here to talk about it.
And the accent gives away the Irish background. So sometimes I mention it in passing that my mother was born in Dublin, so I am an Irish citizen
Nice.
myself. Never been, grew up
Nice.
in Newfoundland, Canada. So, all right, but to the meat of the issue, can you explain the relationship between cholesterol and cardiovascular disease risk?
Absolutely. So cholesterol and cardiovascular disease risk has been, I suppose, a complicated story in some ways, probably more so than it needs to be, in the sense that from the beginning, there's always been a little bit of controversy. So the story of the relationship between cholesterol and heart disease goes back to the early 1900s, 1913. This scientist, Anichkov, who did basically feeding experiments on rabbits where he would feed them a cholesterol-rich diet and saw this pronounced increase in atherosclerosis, which is the development of plaque within your arteries. And from there, that story sort of unfolded, where in the 50s and 60s, we had more epidemiology, which are, observational studies following people over time, suggesting that, okay, cholesterol is important for heart disease risk. At the time, or certainly before that, we were measuring total cholesterol. And then that story evolved further, where we understood that, okay, it's not necessarily the total cholesterol, but there's a difference in the density of the particles that carry the cholesterol. And then from then we started talking about LDL and HDL, low density lipoprotein, high density lipoprotein, which people have probably heard of. And then we've heard more recently about things like ApoB or apolipoprotein B, which is the lipoprotein or the apolipoprotein component that tags those particles, and that's even more important. Again, so that's a very quick whistle-stop tour through some of the history that's gone on in the background. All that to say that our modern understanding is that LDL cholesterol, that's the low-density lipoproteins that carry that cholesterol, they're the particularly important particles in atherosclerosis, or the development of plaque within the arteries. So those low density lipoproteins, when they're high within your blood, tend to deposit within the artery walls over time. And that then leads to this process of atherosclerosis, which it's not just a lipid or fat mediated phenomenon. It's also something that becomes inflammatory over time, involves immune cells, involves smooth muscle proliferation, calcification, loads of different steps in that process. But an early initiating event there is the retention of those particles within the artery wall. So that's mainly the low density lipoproteins, or LDL particles. There are other particles that can contribute to that process as well, but I think that's a reasonable place to start. So ultimately, high cholesterol, but particularly high LDL cholesterol, and particularly if maintained over many years of your life, contributes to risk of cardiovascular disease, specifically atherosclerotic cardiovascular disease, meaning the development of plaque within the arteries. So we might start there, and if you'd like me to go deep on any one of those points, we can take it a bit further.
Well, what causes the accumulation of LDL in your blood?
So we always break down these sort of lifestyle related exposures or any disease exposure, I should say, into those that are related to environment, which includes diet, exercise, etc., and those that relate to genetics. So there's certainly a genetic contributor to high LDL cholesterol, but there's also an environmental component to that, most notably diet. So on the genetic side, if you have a defect in the LDL receptor, or you have a defect in ApoB, or a defect in PCSK9, or various other genetic defects that one can have, you can have a higher chance of having high LDL cholesterol. And in extreme examples, people can have very, very dramatic increases in their LDL cholesterol if you have familial hypercholesterolemia. But you don't have to have that disease in order to have genetically elevated LDL cholesterol. So in summary, there's the genetic side of it. And that's certainly an important point to make on this podcast, because I'm sure a lot of your listeners are into their health and fitness, and they might be eating a pretty healthy diet already. And then they go and get their bloods checked with their doctor, and they realize, oh, I actually have high cholesterol. How could this be? I eat so healthy. And it turns out that there might be a genetic contributor to that. Now, on the diet side, which is probably more interesting because it's modifiable, there are a number of dietary variables that can lead to you having high LDL cholesterol. The first of which that we always talk about is the fatty acid breakdown of the diet. So early on, people thought that it was just dietary cholesterol and high total fat diets that were the problem. Now we understand it to be more so related to the fatty acid composition. So saturated fat in the diet tends to lead to a reduction in LDL receptor expression, which leads to fewer LDL particles being taken up from the circulation, and then more are left in circulation that can be deposited within the artery wall. So saturated fat tends to increase LDL cholesterol, whereas polyunsaturated fat tends to reduce LDL cholesterol. So the fatty acid composition of the diet is important. Trans-saturated fatty acids are also important, but have been largely removed from the food supply now through regulation and improvements in food processing. So thankfully, that's not a major problem anymore, but it would have been up to the early 2000s and even a little bit later in some places. So that's the fatty acid breakdown of the diet. So if you're eating a diet that's very rich in, fatty meats, butter, you're more likely to have high LDL cholesterol. That's not to say everyone will, but we always speak in terms of probability when it comes to these things. Dietary cholesterol is an interesting variable as well, because it's probably the simplest thing for people to intuit when they think, I have high cholesterol, therefore it must be the cholesterol that I'm eating. But that's not entirely the case. The fatty acid composition is probably more important. And then thereafter, dietary cholesterol does still have some relevance. So the food that always comes up in this question is eggs. Should I eat eggs? Is it going to raise my cholesterol? And dietary cholesterol does have an impact on increasing your LDL cholesterol, but it's not necessarily a linear effect. It seems like going from zero dietary cholesterol intake to a moderate amount causes the most significant change. So it's a small effect overall, but there are variances here based on specific genes and proteins within the gut that control dietary cholesterol absorption. So some people absorb more cholesterol from the food that they eat, and therefore will have a more pronounced increase in their cholesterol in response to dietary cholesterol than others. So if you happen to be one of those people, then you're going to be more sensitive to dietary cholesterol intake. And then thereafter, beyond looking at the fatty acid composition of the diet, there are other variables. So generally eating a diet that's rich in fiber, that's rich in whole grains and kind of plant predominant really, tends to lead to a reduction in LDL cholesterol. So that's one of the more favorable decisions that you can make in the diet, as well as some other changes. Like, for example, there are some lipid particles in unfiltered coffee that can increase your LDL cholesterol. There are certain kind of functional foods like sterol/stanol supplements that can reduce your LDL cholesterol. So there are some other things at play, but they're the big things really that we talk about most of the time.
I actually appreciate the reminder on unfiltered coffee because I've been French pressing my coffee for a while, and my aunt, who's a physician, she made a switch a while ago, and she's the one who put me onto this quite some time ago. And I'm like,
Interesting.
I need to figure out another way to probably have my coffee. So we'll see.
Well, it depends on how your bloods are. You know, it's
Mm.
not a massive effect for everyone, and you might get away with it. And I try not to take people's coffee away from them.
Oh, I'll still drink the coffee. I've just got to find a better way to filter it, right? Because French
Yeah,
pressing sort of is in between there. Uh,
exactly. Yeah, you're right.
what are the other lifestyle interventions, specifically on exercise? Does exercise have any direct relationship on LDL cholesterol?
Exercise actually has a very small effect on LDL cholesterol specifically, but it does improve the overall lipid profile. So I only kind of did a brief run over at the start, but when you're looking at a lipid profile, the things that you want to consider, at least that will be available on most routine tests, will be the LDL cholesterol, HDL cholesterol, and the triglycerides as well. So what you generally want as the most favorable profile is low LDL cholesterol, moderate to high HDL cholesterol, and then low triglycerides as well. So generally, if HDL is on the higher side, LDL is on the lower side, and triglycerides are on the lower side, you're doing pretty good. And what exercise does a great job of is increasing HDL cholesterol and reducing triglycerides. And these aren't necessarily causal themselves in that they're more important than LDL, for example, but they do reflect an improvement in overall metabolic health. So, exercise tends to improve insulin sensitivity or reduce insulin resistance. It tends to lead to more favorable body fat deposition, where you're more likely to store fat in healthier places. For example, having less fat around your organs and less insulin resistance, as I said, better blood pressure, etc. So, exercise acts in many different ways. It's like a drug that has like 20 targets as opposed to one. So I wouldn't exclusively focus on the lipid profile when it comes to exercise. Nutrition tends to be a far more targeted intervention when it comes to improving your lipid profile.
Right. One of the things I wanted to set up because is the discussion around LDL cholesterol within the carnivore dieting community.
Yeah.
And we see a lot of, let's just call it bizarre stuff out of there. But one of the things that I may be misrepresenting or even risking straw manning, but I think it's fundamentally what's going on is proponents of the carnivore dieting ideology downplay the role and risk of elevated LDL cholesterol, which is something I understand because they
Mm.
tend to have higher percentages of saturated fat in their diet as a percentage of total calories, then they tend to see elevated LDL cholesterol on average. I think I'm correct on
Hmm.
all that. Please
Yeah,
take that where you need
absolutely.
to.
Yeah, you're correct on that. Uh, So there are indeed a lot of proponents within the carnivore and low carb community that suggest that LDL cholesterol doesn't matter. And the more nuanced position that some of them would hold would be that LDL cholesterol doesn't matter if you are metabolically healthy. They don't entirely define what that means, but often it means the absence of obesity and the absence of insulin resistance, for example. So there's that's not a completely fruitless point in that I would agree that the presence of insulin resistance, the presence of obesity, the presence of other risk factors, and the presence of an overall poor diet quality would amplify the effect of elevated LDL cholesterol on risk of heart disease. But that's not to say that LDL cholesterol on its own is not a relevant risk factor. And a reasonable test of that really would be people with heterozygous or homozygous familial hypercholesterolemia. So those are those people who live with elevated LDL cholesterol throughout their lives through a genetic cause, irrespective of the rest of their lifestyle. So those individuals tend to be at a dramatically increased risk of cardiovascular disease. Now, the kind of pushback on that a lot of proponents of carnivore diets will give is that, well, I know someone who's been eating carnivore or had high LDL cholesterol for 40 years and they have not had a heart attack. And that's a fine point. But the thing that's important is we always speak in terms of probability when it comes to risk of chronic diseases. Because going back to the beginning, high LDL cholesterol is thought of as being a risk factor for cardiovascular disease in a cumulative manner. So it's all about cumulative exposure. So the more exposure you have over time to LDL particles in circulation, the more likely you are, all else equal, to have significant coronary artery disease or atherosclerotic cardiovascular disease. But it doesn't mean that everyone is going to have that, some of which we understand and some of which we don't. And that's the case with pretty much every disease. It's the same reason that we have people who have, smoked all their lives and seemingly haven't had any complications associated with it. So it's not a case of 1:1 or high LDL equals heart disease in every person to the same extent. That's certainly not true. Now, with respect to the carnivore diet and low carb community in particular, you can pick out anecdotes of people who do have heart disease and have had heart attacks and strokes while on the carnivore diet. But then again, you can find anecdotes of people who have never had heart disease. So these aren't points that are to be made as in support of either of those positions. And what we have to do is look at the body of evidence as a whole and ask ourselves, is there evidence that LDL is causal in risk of cardiovascular disease? And the answer to that, based on Mendelian randomization studies, i.e. genetic studies, interventional studies, observational studies, overall, the evidence would favor that being the position that's most likely to be true. Now, it's possible that someone that's on a carnivore diet may gain such a benefit from the weight that they've lost, the improvement in their insulin resistance, the improvement in their blood pressure, the improvement of their overall health outside of their lipids, that they might get away with, so to speak, their increase in LDL cholesterol because they've improved all of the other risk factors. But the question that we always ask is, what does a change in a given risk factor, all else equal, do? So the comparison of someone that's lost 40 kilos, improved their blood pressure, improved their insulin resistance, and had an increase in their LDL cholesterol. The question of that person's risk is to compare that against someone who has all of the favorable things and low LDL cholesterol. I think it's very difficult to make the case that having high LDL cholesterol would be more favorable in that circumstance. So I don't think there's a strong argument really from people in the low carb or carnivore diet community that LDL cholesterol doesn't matter. And to be fair, there are proponents in that community that will say, yeah, LDL probably does matter, but because I'm improving everything else, I'm not worried about it. And that's an okay position. I don't think it's the best position, but it's reasonable. However, there are also people in that community who say pretty explicitly that LDL just doesn't matter, and this is all just, pharma trying to make money. And I think that's a totally incorrect position, really.
And your point does make a lot of sense that if you get someone in this real dichotomy in some cases who's significantly overweight, otherwise their lifestyle behaviors are very detrimental to them, and then they decide for whatever reason that carnivore is the way, they dramatically reduce their calorie intake. They maybe get more active directly or indirectly as a result of the other changes. And then they lose a whole bunch of body fat, that their insulin resistance improve or insulin sensitivity improves, like you said. It does make sense, but I'm grateful for the way you broke that down, because that you just hear a lot of weird stuff out of that camp. So now
Yeah, and I
you
mean,
mentioned,
sorry, I was just going to say, I have spoken to people like that some people who have done carnivore, lost lots of weight, and then moderated their diet thereafter, where they introduced some plant foods, they introduced some whole grains, and now they've maintained their weight loss, but they eat a bit of a more balanced, kind of normal, nutritionally appropriate diet, and they've done well with that. So, I'm not saying that people should never try diets that are extreme, let's say, for a certain period of time. But I would just be very careful about the claims that are made and the total and the intent of the diet long term,
and it's slightly outside the scope of this, but I've also long said that you often get people who fall into carnivore dieting because they have just unknown dietary intolerances. It might be a FODMAP intolerance, which could be really nebulous and hard to pinpoint,
Sure.
and they feel better. But the mistake they make is that, oh, this is evidence that this is technically superior and everybody should do it. No, you just did a very extreme elimination diet. You felt better. You probably dropped your calorie intake as well, which may also contribute to feeling better. And then the wise move is to reintroduce things and maybe figure out the things that are disagreeing with you, not to stay carnivore for life.
Yeah, exactly. And that's the case with most elimination style diets. The general intent, if led by a dietitian, for example, would be to remove those foods and then to gradually reintroduce and see what is causing the issue, as opposed to just going with full elimination forever. And you do see people eventually sort of owning up to their losses there, where people have been carnivore for a year, and at that time they were singing its praises as the best diet in the world. And then 2 years later, maybe they started introducing some stuff, and then 5 years later, they're saying, I was wrong about being fully carnivore. We've seen loads of high profile carnivore influencers have that transition. I think that should be a reminder to the point that you just made, that maybe this is a vehicle towards finding a diet that suits you better, as opposed to being something that you should eat for the rest of your life.
This episode is brought to you by Just Bite Me Meals. I work long days and I won't compromise my client experience or sacrifice my workout, sleep, or nutrition. So I needed a quality and reliable meal prep service so I could save time on cooking and shopping and have more time for the stuff that matters. Net out the cost of groceries, and a service isn't as much as you might think, and regular impulsive food delivery apps, eating out, that costs way more anyway. I get more meal variety and less dishes to clean, and I've been referring clients to Just Bite Me Meals for a long time, and I recently started ordering myself. Food is great. The beef brisket tacos are my favorite so far, and there's a lot of menu choice. Your calories and macros are listed. The portions are great. You can order custom meals. They deliver to your door, or you can pick up from their storefront. And I'm sorry to listeners outside of Alberta, but Just Bite Me Meals is currently just in Edmonton, Calgary, Grand Prairie, and Fort McMurray. Ordering from Just Bite Me Meals made my life easier instantly. And you can get 10% off on all your orders using my code, Andrew Coates Fitness, all caps, on their website. That's Andrew Coates Fitness, all capitals, or go to the link and the code in the show notes. What's the relationship between obesity and cardiovascular disease risk? You mentioned a few times. I think anybody who's a longtime listener knows that every once in a while I'll sort of like poke at this, that I think this ideological lie got really out of hand, and most people were afraid to push back against it several years ago. Now I think we're past the Overton window on that one. So what's actually going on there?
Yeah, you're right. I remember it was probably like the 2019 to 2021 period. There was certainly a lot more people, even in the sort of evidence-based community, that were leaning in the direction of, okay, maybe it's not the obesity that actually matters for disease risk. Maybe it's just the behaviors, maybe it's stigma and other variables, as opposed to obesity itself being harmful. I think that's really quieting down. I think most people understand now that obesity itself, the fat itself, as an active tissue in the body, is causal of disease through multiple different mechanisms. Specific to cardiovascular disease, there are multiple different mechanisms through which obesity can cause harm. For example, having excess body fat, particularly body fat that is visceral in nature or ectopic in nature. For example, fat that's deposited within the liver, within the pancreas, even around the vasculature, and around the heart. All of that is the most kind of high risk type of body fat. It tends to be inflammatory in nature. It tends to be associated with insulin resistance. It tends to contribute to elevations in blood pressure and worse lipid profile overall. So it sort of has this effect where it acts on multiple different systems to contribute to risk of disease, both atherosclerosis, but also other types of mechanisms towards heart disease. For example, obesity, by increasing the inflammatory state, by increasing sympathetic nervous system activity, increasing activation of the renin-angiotensin-aldosterone system, all increased risk of high blood pressure over time, and then subsequently increased risk of heart failure. For example, heart failure with preserved ejection fraction is something that is strongly associated with obesity and sort of metabolic syndrome more generally. So obesity is something that is, I suppose, a little bit of a hidden risk factor in a way, because it's often not included in risk calculators for heart disease. It's often not thought of in the kind of usual schema of blood pressure, smoking, cholesterol, the things that we, can treat. Obesity has always been a little bit of an insidious one because it is so difficult to address. It often requires multiple different interventions to address Now, some of that is obviously changing with the advent of the weight loss medications, which are rapidly progressing. But obesity is a risk factor that I think, if addressed on its own, takes care of multiple other risk factors, which is why it's such a powerful sort of risk multiplier in a way. Because if you have someone with obesity that has atherogenic dyslipidemia, which is the type of lipid profile that tends to be most associated with the development of plaque, i.e., high LDL, high triglycerides, and low HDL. And that person also had insulin resistance and high blood pressure. If you've got all those things going on at once, and then you lose loads of weight, all that weight around your midsection comes off, subsequently your blood pressure is better, your insulin sensitivity is improved, and your lipids are improved, it's almost like you've treated three separate things via that one mechanism of losing weight. And that's kind of what I talked about with respect to exercise as well. And that's what a good diet does as well. They all act through multiple different mechanisms. And I think that's really where obesity sits. So obesity itself contributes to risk, but the behaviors associated with obesity and that contribute to it are also powerful contributors to risk. So that's why it's always been difficult to isolate that effect.
It makes sense that they're all sort of magnifiers of each other. They tend to go hand in hand, a bunch of these behaviors and outcomes. And therefore, if you address some of them, you see improvement in everything, like you said. And so it magnifies potential good outcome, or the other way, the bad outcome. You mentioned the disposition of body fat in different places. And I know some of the stuff is genetic, some of the stuff is gender-based. But can you explain in a little bit more detail the difference? Because we know that, I mean, then there's the whole BMI discussion, right? Which sometimes, again, people will lose their minds about. But there's definitely truth that across, even, again, ethnic background, we see differences in what BMI points to when it comes to cardiovascular disease risk. And again, like I said, gender. So I think women are more likely, on average, to have more fat deposits on hips, thighs, which is not as risky as the visceral body fat around your midsection, right?
Correct. And this is something you see as early as adolescence. But before we get to that point, the thing that people need to think about here is, normally when we store body fat, what happens is we're in an energy surplus. The body decides, okay, we need to store energy. And the first place it usually goes is into subcutaneous adipose tissue stores. So this is the fat that you feel underneath your skin. If you were to grab your arm or your leg or your tummy, it's generally the fat that sits right under the skin. And that's your first sort of energy store. But there's a limit to that store in a way. And it depends on the size of your fat cells and how many fat cells you have. And there's a strong genetic contributor to that. And as those fat cells begin to expand and begin to get full, there's sort of an overflow effect, whereas those fatty acids or triglycerides will be stored elsewhere, such as on their way, they get stuck in the liver and they get stored in the liver. And then move from the liver, they can get stored in the pancreas, and they can be stored around the vasculature or around the heart or around the kidneys, perinephric fat. So there's other places that fat can be stored once it spills out from under the skin. And this then begins to lead to more problems that we tend to see, like the atherogenic dyslipidemia I talked about, elevations in triglycerides within the blood, and insulin resistance. So this cycle begins to then kind of propagate itself from there. So that type of fat is something that we generally see more associated with a wider waist or a greater waist circumference. So if you tend to store more weight around your midsection, you're generally going to have more visceral or ectopic adipose tissue. There's not a one-to-one relationship, as there often isn't with anything in biology. Like, you could have a sort of a normal waist circumference, and that seems like it's within a normal range, and still have fat around your liver. But generally speaking, the greater your waist circumference and the more fat you store there relative to other areas of your body, the more likely you are to have more visceral adipose tissue. Males tend to be more susceptible to this. So a typical sort of android body fat deposition pattern would be more weight around the midsection, less on the legs and the remainder of the trunk. And what we see there is that early on in life, even in adolescence, young men tend to have more visceral adipose tissue. And this probably goes part of the way to explain why men have higher blood pressure earlier on in life, but then women actually catch up over time. So their blood pressure rises to a greater extent, even though it's not higher at the time, throughout their kind of 20s, 30s, 40s. And it's then generally around that kind of perimenopausal transition in women that you see blood pressure start to catch up. And I'm only mentioning blood pressure there because it's related often to visceral adipose tissue. And you see more visceral adipose tissue in women around that age bracket as opposed to earlier on in life. So yeah, men are a little bit more vulnerable to that. And the more, obviously, the more body fat you gain, the more likely you are to have visceral adipose tissue. But there are just simple, as you said, sex differences, but also genetic differences and ethnic differences. So we see in, for example, South Asian populations, they tend to be more vulnerable to visceral adipose tissue and central adiposity. And as a result, there are ethnic adjusted sort of BMI norms, because at a BMI of 25 in Caucasian populations, you're less likely to have deleterious outcomes associated with your obesity than a South Asian person at the exact same BMI. Now, this isn't to say that BMI is useless, which is obviously a very popular view in our industry. People say that BMI doesn't matter, but the reality is that BMI does matter, but it's intended to be used at a sort of population scale primarily. And when you're looking at an individual in front of you, you should be able to tell if this is a 100-kilo guy who's just jacked out of his mind because he, played rugby or American football, or this is someone that has, clearly significant body fat body fat. And the thing is as well is that even in gym goers, it's actually quite rare for someone to exceed a BMI of 30 in the absence of significant amounts of body fat as well, at least naturally. It's not very common. It does happen occasionally, but it's not very common. So if your BMI is over 30, the probability is that you probably would benefit from being at a lower level of body fat. And that's not to say that body fat or the threshold is the same for everyone, because going back to what I talked about earlier, there is this concept of the personal fat threshold where each individual is going to have a different level at which they spill more of that fat over into their blood and onto their organs, as opposed to being subcutaneous underneath the skin. And that's that point at which that person will begin to experience the harms associated with their excess body fat, as opposed to someone else. And then one more point on that is that the relationship between obesity and disease outcomes or poor metabolic health is not merely magnitude dependent, i.e. not only dependent on how much body fat you have, but also time dependent. So there was a lot of talk 10 years ago or longer about metabolically healthy obesity. But when these people with so-called metabolically healthy obesity, i.e. people with obesity but without significant metabolic derangements as a result, when they're followed up over 5 years, you see more of those people transitioning over into the metabolically unhealthy state, and then you follow them over 10 years, and even more again have gone into that metabolically unhealthy state. So I would prefer to think of obesity as being something that does contribute to cardiovascular disease risk, but to varying levels in different individuals. That is dependent on both genetics and where they store their body fat, and how long they actually carry that body fat for. So all of those things matter together when thinking about obesity and heart disease risk.
It's sensational, but it is a ticking time bomb, essentially.
Yeah, I mean, like it's kind of similar in a way to how I think of the cholesterol story that we started with. The way that we think about LDL is through cumulative exposure. It's about magnitude by time, and it's the exact same with blood pressure. That was the purpose or the topic of my master's thesis, was on the cumulative exposure to blood pressure and how that actually impacts cardiovascular disease risk. So the problem is we think of these things as static high or low thresholds. So you see that when people are making decisions about whether or not they should take a medication or whether or not they need to address their high blood pressure, the question is never, is it high or is it low? But how high is it? And for how long is it elevated? That's what contributes to disease risk, not just these binary categories.
Right, we've talked about blood pressure a fair bit. So what causes high blood pressure?
Yeah, so high blood pressure is contributed to, again, sort of similar to the cholesterol story, genetics, environment, but genetics always sort of loads the gun in a way, and then the environment pulls the trigger. And I've touched on a few of these points already. So obesity, and particularly that visceral adipose tissue that I mentioned, contributes to elevated blood pressure. It does that through multiple mechanisms, stimulating the sympathetic nervous system, increasing fat around the blood vessels that can contribute to inflammation. There's generally a chronic inflammatory state associated with significant obesity, and particularly visceral adipose tissue. Activation of different molecules that sort of stiffen the blood vessels over time and lead to sodium and fluid retention, such as the renin-angiotensin-aldosterone system. The mediators related to that all contribute to high blood pressure. So obesity is kind of a big one there. The other things that are related to that are insulin resistance, which is part of that same process. But a big one in the modern diet in particular, depending on where you're living and how you eat, is high salt intake. So having a high salt diet tends to contribute again to high blood pressure, depending on how active you are and depending on how salt sensitive you are to a varying degree. So for example, if you're someone that works in very hot conditions and you run marathons, you're probably going to get away with a higher salt diet. That's also the case if you're someone that eats an otherwise clean diet, but maybe just adds salt. So for example, if all of your diet is plain chicken breasts, broccoli, rice, etc., loads of plain foods, and then you add loads of salt on, you're probably going to get away with that versus the person that eats a diet that is very rich in processed foods. So that's what we tend to see, is that salt intake in the modern diet tends to come primarily from prepackaged foods, snack foods, the typical ultra processed foods that people think about, as opposed to added salt at the dinner table. And most countries that your listeners probably live in are consuming maybe between 8 to 10 grams of salt per day versus the 4 to 6 grams that is recommended. So most people already consume high salt diets, and in some cases they supplement that with added salt at the dinner table or electrolyte supplements, which are primarily just salt. So salt in the diet is very significant, and it's probably more significant in the context of obesity and metabolic syndrome, which are very much related to high blood pressure as well. There are some other variables. Smoking and nicotine can increase blood pressure. Alcohol can increase blood pressure. And even caffeine in some people can have varying effects on blood pressure. It's not so significant in some, more significant in others, probably most important at high doses. And other stimulants as well can all contribute to high blood pressure. Sleep loss is another thing that can raise your blood pressure, and especially sleep apnea. So if you have obstructive sleep apnea that's untreated, that again can contribute to high blood pressure. So quite a few different things there that can feed into that process.
So keep an eye on your blood pressure, mind your salt intake.
Yeah, I mean, the interesting thing is that like so much of this just comes back to the same behaviors over and over again, whether we're talking about lipids or blood pressure or diabetes risk. Maintain a diet that is generally healthful by the standard pillars that we always talk about, that everyone talks about. Reduce your salt intake, be active, try to get enough sleep, maintain a healthy weight. If you do all that and you don't smoke, you don't drink much, and you're not using other substances, most of your risk factors will be pretty good, other than those that are really just genetically perturbed.
So what do you recommend for people screening for something like plaque in their arteries? Because obviously, if someone's experiencing obesity, they kind of know. They don't really need to be beaten over the head with that one. But if you are otherwise maintaining a normal BMI, but you don't know what's going on, with your cholesterol, what do you suggest? And I'll try to frame this a little bit more, because my friend Joel Jameson, I know, did a presentation. He was talking about there is soft plaque, and then there is the calcification of plaque. And I believe there is a scan that will just show you the calcification, but it may not show you the soft plaque, which is risky.
Yeah, so there are three different ways, primarily. There are more, but three main ways that you can get a sense of whether or not someone has coronary artery disease. So that's the plaque within the arteries around your heart. The first is the way that people probably know the most about, or maybe you've seen in the movies or you've heard about family members going for, which is an invasive coronary angiogram. So that's what someone goes for when they have the dye injected into their arteries. And that's generally for people who are either having a heart attack, they've already got chest pain, or they're at high risk. The pretest probability is quite high that they have significant coronary artery disease. That's probably the most classically used for those high-risk people. That's where a catheter goes into your wrist, up into the artery, and is inserted into the heart. Dye is injected through catheters into the arteries under X-ray guidance, and then you get a picture of what the flow is like in those arteries to see whether or not there's any obstruction. And that's important for those really high-risk people and people who are having chest pain, symptoms, etc. That tends to be when that's used. That's not the question that we're asking here. Usually what we're talking about when we're talking about screening is taking a particular test in people who do not have symptoms for the purpose of preventing downstream disease or events. So the goal of screening should be that we pick up something that we can then make a decision on to prevent a bad outcome in the future. Because if you're screening for something that doesn't actually change decisions, then it's pointless to screen in the first place. The goal is to make a decision on the basis of screening, particularly if it's something that's done at a population level. So currently there's two different ways, not in a non-invasive manner, i.e. not getting an invasive coronary angiogram, like I said, to look for plaque in the arteries. The first is, as you said, looking for calcified plaque. So that's a coronary artery calcium scan, which is a type of limited CT scan that looks to assess how much calcium there is within the arteries. And generally you come out with a score. The Agatston calcium score is what's often used. And this tells you how much calcium you have in total within your arteries and how much you have within each artery. So for example, you'll often get a value like your left main coronary artery, left anterior descending, your right coronary artery, and your left circumflex artery. Usually you'll get those four results and a score in each of those to tell you where the calcium is if it's present. So the coronary artery calcium test will tell you how much calcium there is in the arteries, but the limitation of it is that it won't tell you about non-calcified plaque. So calcification tends to occur as the disease progresses. So early on, a plaque will be lipid-rich or fatty in nature, and then will become more calcified or fibrotic with time. So it becomes harder, essentially. So what a coronary artery calcium scan is used for often is risk modification, as opposed to, or risk stratification, I should say, as opposed to trying to detect whether or not there's any disease at all. So, for example, if someone was on the borderline based on a conventional risk score as to whether or not they should be treated with a statin, a coronary artery calcium score might be used as the sort of decision breaker in a way to decide whether or not you start a statin. So, for example, if someone is at intermediate or low risk, but you're having this discussion with them and they subsequently have a positive coronary artery calcium score or very significant coronary artery calcium, then the decision might be made to pursue lipid-lowering therapy with something like a statin for risk reduction. But if the score was 0, then the point usually is that there's some reassurance there. And there is some evidence to support that. However, I tend to think about it a little bit differently myself. I think that, if you've got a burden of risk factors on its own, and you're younger in life or in age, then I think it's reasonable to start on the basis of risk factors alone, whereas often this score is used in a way almost to kind of convince people if they're a little bit uncertain or a little bit unsure. And the guidelines suggest at the moment, so a coronary artery calcium scan would be used for risk stratification in men over 40 and women over 45. So, I'm 31 at the moment. If I had elevated LDL cholesterol, I was wondering about my risk, I wouldn't want to be waiting until I'm 41 years old to start addressing that risk factor. So coronary artery calcium score, that's what that does, calcified plaque. A CT coronary artery or a CT coronary angiogram or a coronary CT angiogram, CCTA or CTCA, depending on the acronym that's used, that is typically uh, going to be better for detecting that soft plaque. So when you do a CT coronary angiogram, you can see that calcified plaque for sure, but you can also see plaque that is non-calcified or fatty in nature. So that's where the non-calcified plaque volume will come from. If you're reading certain studies or you see talk about this area, you get non-calcified and calcified plaque. So this is where you're actually looking at the arteries with a CT scan, and you're going to get a sense of whether or not there's obstruction. So often the way this is reported is something like, mild stenosis or mild non-calcified plaque or moderate non-calcified plaque or severe stenosis, depending on how significant the disease is. And there's various AI software tools that different reporting hospitals or hospital systems will use to try to quantify that. But generally speaking, that CT coronary angiogram is going to be more sensitive for detecting plaque overall, beyond the coronary artery calcium score, which will just tell you about the presence or absence of calcium.
I'll interrupt this episode for a quick but important side quest. While I don't think everybody needs to track nutrition all the time, tracking is one of the most powerful tools to make sure you're not eating too much or too little. And Macros First is my go-to app for me and my clients. Macros First has a free barcode scanner, and a premium version comes with a bunch of cool stuff to make managing your nutrition easier. Like, one, AI search. AI is everywhere now, where you can speak or type the foods you wish to save and log everything without having to search for each individual ingredient. Two, import recipes from a website. Save time creating recipes manually by importing all ingredients and instructions from your favorite recipe websites. No more searching for each ingredient one by one, just paste in the website. And three, this one's a big one for nutrition coaches. Follow unlimited friends so you can follow all your clients. And there's a lot more cool features. You can try the premium version of Macros First free for 14 days. Just download Macros First from the App Store. And during setup, you'll be asked, how did you hear about us? Type in the code Andrew. 31 years old, huh? Wow, that's quite the accomplishment of career in just that short amount of time. And here I am at 48 thinking, well, some risk factors accumulating. So thank you for the breakdown of the two different tests. Because I'm thinking to myself, I really actually should get the CCTA. One last thing. Do energy drinks or caffeine in general increase the risk of heart problems? You made a brief mention earlier. I like my White Monster energies. I like my coffee. And funny enough, I wasn't much of a caffeine person until I was probably about 37. I never drank coffee in university.
Really? Wow. And what did you do in university?
Bachelor of Commerce degree.
Nice.
I
Okay, so the
wasn't in,
commerce students, they weren't slamming coffee,
I wasn't an
Med
engineering student. And funny enough, I was originally doing life sciences and thinking about medicine because there were a fair number of doctors in my family. Very
Oh,
proud of my
wow.
grandfather. My grandfather from Ireland was a chief of staff and chief of radiology of St. Clair's Hospital, pretty much the architect of that hospital and the associate dean of the medical school there. So there's some
Amazing.
legacy there, but I just decided not to follow that path.
That's epic. That's epic. So energy drinks and coffee. I suppose the central kind of focus there is caffeine. We probably have better overall evidence base on coffee. And when you look at sort of observational studies, it seems that coffee is sort of neutral for heart disease risk. Like you can look at some evidence that shows that heart or coffee might actually be protective, but I try not to overinterpret that because clearly I'm bringing bias to the table there. So overall, I kind of tell people not to worry about coffee so much, really. That's not to say that it doesn't matter. Caffeine itself is stimulatory. It is a stimulant, and energy drinks in particular, it is possible to rack up a pretty strong caffeine intake if you're drinking them regularly. Like I do know some people, I've even met someone in clinic who was drinking, 3 back-to-back Monster Energies and getting palpitations associated with that. And I think if you're at that point where you're feeling your heart fluttering or racing in your chest and you're having these energy drinks, that's probably something that you want to address. there is evidence that, high caffeine intakes can increase PVCs, or premature ventricular contractions, which just suggests that your heart is kind of having an extra beat. You'll occasionally feel that in your chest. But the overall evidence in favor of harm at sort of low to moderate intakes of caffeine isn't very strong. We don't have that much good evidence on energy drinks. And the problem is that there's a lot of confounders in this area of research, where if you're drinking a lot of energy drinks, there's, in an observational study at least, that's probably going to be associated with other poor lifestyle behaviors, and a reason for the energy drink consumption. For example, if you're having 4 Red Bulls a day, you're probably not sleeping very well. Your lifestyle overall probably isn't great. And maybe we're not capturing all of that in the existing research. So what I say to people generally is, I'm not too worried about people having, a couple of cups of coffee per day. If you already have high blood pressure, existing heart disease, particularly like funny heart rhythms, or rhythm disorders, you might want to keep an eye on your caffeine intake or limit it, particularly if you have symptoms associated with it. But if you're having a couple of coffees a day, even an energy drink, because I drink White Monster as well, I'm a big fan. I'm just not worried about that for most people. But if you are in a clinical population where you already have established symptoms or a particular disease, I would always pay a little bit more attention and lean on the conservative side. But what I can't say is that we have great evidence that people need to restrict or avoid caffeine, particularly in the absence of an existing disease or symptoms. And we even have evidence that, you know, caffeine, coffee versus decaf coffee probably doesn't make too much of a difference in terms of risk of atrial fibrillation, for example, which is one of the most common heart rhythm disorders. But again, our evidence is quite limited. So overall, my rule of thumb, have your couple of coffees, not a big deal. Have an energy drink here and there if you want it. Choose the 0 sugar version. That's definitely preferable. But just try to take it handy. The general kind of recommendations from nutrition guidelines is like 400 milligrams of caffeine per day, which is, a White Monster and probably 2 regular cups of coffee, maybe,
That's my
depending
day.
on what type. What's that?
That's my day. And
Yeah.
I suppose also there's got to be a little bit of allowance for body weight because I'm 240
Yeah.
pounds, so I'm assuming that actually scales with body weight. So I probably have a little margin there, right?
Yeah, you got a little bit of room, or at least I'll tell you so. No, yeah, I would say, yeah, you definitely have a bit of room depending on body weight and caffeine sensitivity. I'm not caffeine sensitive at all, to be honest. I don't particularly feel the effects of it. Occasionally I'll get a perk here and there, but doesn't make much of a difference. I know some people who they can have one coffee and they're wired to the moon, and they feel their heart racing. That's someone that might be more likely to have problems associated with caffeine, particularly if they're feeling their heart racing after it. My heart rate doesn't tend to change much after having caffeine. If you're someone whose heart rate is increasing by 20 to 30 beats, then that suggests that you're really affected by the stimulant properties of caffeine. So overall, I'm not too worried about it. Coffee, neutral to potentially beneficial, depending on how you want to read the evidence or what you want to tell yourself. Energy drinks, I'm not going to make any claim about energy drinks being good for your heart. I don't think that's the case. But I also don't think they're as dangerous or worrisome as some people like to make out. But I am worried about some young people that I have encountered who, are really borderline addicted to these things. And there are some case reports of people who have had extremely high energy drink consumption, presenting with real heart problems, acute heart failure. Whether or not it's causal is hard to say, but it's certainly worrying. There are some case reports like that in the literature, particularly some of the US energy drinks, Bang Energy and things like that, where you can get 300 milligrams of caffeine. I've seen guys mixing those with pre-workouts. I'd be careful of that. But at the same time, if you look at the exercise science literature on caffeine, most of the studies use 6 to 8 milligrams per kilogram or more for benefits in sports performance. There's studies of 10 milligrams and 12 milligrams per kilo, which, if you're 100 kilos and you're having 8 milligrams per kilo of caffeine, that's 800 milligrams or over 5 cans of Monster. So these doses have been tested and are beneficial for sports performance, but you've got to be balancing that with risk and your individual susceptibility. So health and sports, they don't always tie together. So take care in using that too.
To your point, I remember, and I'm pretty sure it was Greg Nuckols and Stronger by Science. They tend to do these longer review articles, really in
Yeah.
depth, really evidence-based. And I'm pretty sure it was something on how the purported benefits of caffeine, especially like just having a coffee before a workout, just simply wasn't very strong. The data in performance enhancement was in higher doses than this.
Yeah.
And then these extreme outliers, like I keep thinking about, every once in a while you'll hear about some, South Korean StarCraft player who lived on Red Bull for 4 days, didn't get any sleep, and dies of a heart attack, right? Those are extraordinary
Mm.
outliers. And I don't think we could attribute that to say, like, hey, having an energy drink a day is somehow harmful. Gary, your media is fantastic. One of the goals with my show is to actually point people to follow you, to find you, and to learn from you. I love the way you communicate this stuff. So everybody can get you on Instagram. You're active there at Dr. Gary McGowan. So Dr. Gary McGowan. Is there anything else you want to point people to?
So that's me. You'll find most of what I do on my Instagram page. I do have a coaching company and education company called Triage Method. You'll generally find me talking about that there on my page. So
Mhm.
we offer fitness and nutrition coaching, injury rehab coaching, but we also do education for trainers. So we've got a nutrition course, we've got an exercise course, and we've also got a couple of new tools such as our triage health tool where people can plug in their blood test results like their lipids and their lifestyle and all these kinds of things, and it will make a recommendation or an assessment of how you're doing. So we're trying to basically cross this bridge between healthcare and fitness and help people to navigate what is a really confusing area at the moment, as I'm sure you're aware from the online space. So I just want people to make good decisions, but also to live their lives not worrying about every last variable of their life, which is unfortunately the trap that I think people fall into these days, over worrying about what underwear they're wearing and all these silly things that I see influencers talking about. I want you to focus on the things that really matter, and that's what I try to get across in my communication.
Oh, it's fantastic. And I'm utterly astonished that someone by the age of 31 is already, master's degree in preventative cardiology, medical doctor, physical therapist, and had a career as a personal trader, and then built an online coaching business as you were doing all this stuff. That's very impressive.
And
Congratulations.
very tired. You're very tired in the way. No, thank you. I appreciate it. It's been I just I just love this crossover. I'm just a meathead who also likes to study. I'm like I'm just your gym bro who likes studying
Hmm.
and likes progress. So that's I just found myself in this weird sort of niche as a result.
All right, everybody listening, please go follow Gary. You get a pretty clear picture if you hung around as to why he's a great resource. Gary, thanks for taking the time. Go enjoy the World Cup final. We'll chat soon.
My pleasure. Thank you.